Pew pew. Diam-diam bye guys. Salah aku. Assalamu alaikum.
Waalaikumsalam.
Waalaikumsalam.
Yesterday we start new topic anti antidepressant. We discussed the name yesterday SSRI, SNRI, monoamine oxidase inhibitors, category B, and tricyclic antidepressant. Okay, let's start. So first we discuss SSRI, selective serotonin reuptake inhibitor. Selective serotonin reuptake inhibitor, the name lists paroxetine, paroxetine, fluoxetine, sertraline, sertra, sertraline, stelobram, stelobram, estelobram, stelo and estelobram. So these drugs, how these drugs are working? These drugs working, they block the reuptake of serotonin. So which is the area of the brain? The problem inside the brainstem. Inside brainstem. The neurons here inside the brainstem, norepinephrine decrease and serotonin also decrease. Here we're discussing here the 5-HT. So these drugs, all these drugs working on these neurons, the reuptake here, the protein taking back serotonin into neuron, presynaptic membrane. So these drugs, SSRI, selective serotonin reuptake inhibitor, they work here and increase 5-HT, increase 5-HT in synaptic space. So the increasing 5-HT, but the problem in depression, the problem in depression, this neurotransmitter 5-HT was low. Okay, 5-HT. Our principle of therapy, we must increase 5-HT. We must increase 5-HT. Then they inhibit reuptake of 5-HT and 5-HT increase, so you can treat depression. So what are the uses of these drug and side effects? The uses, the first thing we use for depression, of course these are antidepressants we use for depression firstly. So these are the gold standard drug to treat depression. Must keep in mind, the best drug to treat depression. The first line therapy to treat depression, SSRI. Must keep in mind, okay? Not go for other group. First, you must start SSRI. These drugs first we use for depression. Another, if person like generalized anxiety, GAD, generalized anxiety disorder. It's not specific in anxiety, generalized anxiety. For an anxiolytic, we're having better drug option, GABA drug, alprazolam, midazolam, triazolam, oxazepam, temazepam, amobarbital, secobarbital, okay? Barbiturate and benzodiazepine for anxiety. So the first therapy for depression, we also can use for an anxiety disorder, general anxiety disorder, generalized anxiety, okay? So very important use of this drug we use in obsessive compulsive disorder. Obsessive compulsive disorder. Okay. Another another use obsessive compulsive disorder in female. In female, bulimia nervosa. Bulimia nervosa. They are not taking food just because of fear having overweight. Bulimia nervosa, anorexia nervosa. Okay. So bulimia nervosa and bulimia nervosa, these female they eat, but they self-induce vomiting. Self-induced vomiting. It's a nervous problem. Yeah, it's a nervous problem. Okay. So for bulimia nervosa, so we also can give because they have problem just thinking they're depressed or they're getting overweight. They're getting overweight. Even they are less than 40, their BMI less than 18. BMI less than 18, underweight. So bulimia nervosa and stress and another issue. If you have any trauma in your life, like you have seen any accident, post traumatic stress disorder. So these drugs are very effective for these illnesses also. The first preference we use for depression. Okay. First we use for depression. Okay. Generalized anxiety disorder, obsessive compulsive disorder, bulimia nervosa, post traumatic. If any accident in your life and you and the person like uh, the parents killed by someone in front of their children, and those children they develop stress, they're having an anxiety because they have seen the in reality how the killer the kill their parents like this. It's a trauma. It's a trauma in their life. Yeah. Post traumatic stress disorder. You seen any accident in front of you, like accident the person on walking on road and one vehicle come and run over the person, and now you are feeling scared just because of that scene, very bad scene. Yeah. So like this, post traumatic stress disorder, bulimia nervosa, obsessive compulsive disorder, general anxiety disorder, and depression. So we can prefer these drugs. Okay. The first line therapy for depression, you must go for SSRI. And another very important thing you must explain to patient when you start therapy, 4 to 8 weeks. 4 to 8 mean 1 month to 2 months. Okay, 4 to 8 weeks, 4 weeks, 1 month, 8 weeks, second month. Okay, 1 to 2 months. These drugs they're not improving depression. These drugs just producing side effects. You must explain to patient family member. Okay, so the improvement will come after 1 or 2 months. Improvement will come after 1 or 2 months. Understand? So these drugs they're working a bit slowly. They first producing side effect. Understand? They first producing the side effect, the beneficial effect later. Done. The first 4 to 8 weeks, first 4 to 8 weeks, they no benefit to patient. Just patient taking medication, but still the family member, the family attendant, the patient attendant, they complain, hey, doctor, we're using medicine from 1 month, from 2 months, but still person in depression. Yeah. So you can explain this thing before using SSRI. SSRI, you must explain. Okay. Because so these drugs take longer time for proper response. It take 1 or 2 months. 1 or 2 months, like proper proper therapeutic effect. For proper therapeutic effect, it take time. Okay, you must explain to patient. Done. So this thing you must explain. So what are the side effect of these? Side effect, the important side effect. The serotonin, where we use serotonin. Serotonin we also use in GIT. Okay. The serotonin, the most common side effect, decreased libido. It's the most common side effect. The sexual desire of male female both decrease. Decreased libido. decreased libido in both male as well as female. This is the reason. So why this not used for much longer time? This is a big reason. Not used for much longer time, especially in young patients. Okay, decreased libido is the most common side effect of SSRI. Another side effect. So these drugs they're releasing ADH, SIADH. They're releasing ADH too much, severe, inappropriate ADH, very high level of ADH, very high level of ADH. Another drug release ADH is carbamazepine. It's from epilepsy group. Okay, one is this one. SSRI, they also releasing very high quantity of ADH. So they stimulate pituitary, posterior pituitary, hypothalamus to release ADH. Okay, so SIADH another side effect. And third one, because they increase serotonin level, so serotonin syndrome, serotonin syndrome, serotonin syndrome. Because of high level of serotonin, they also yesterday I explained one side effect. Wet, wet pillow is just a drooling of saliva. Okay, morning time, wake up, too much drooling of saliva, drooling of saliva. So what is serotonin syndrome? Yesterday I asked you one question, neuroleptic malignant syndrome. So neuroleptic malignant syndrome is a complication of using like long-term use of antipsychotic drugs. Okay, because neuroleptics are also antipsychotic, another name for antipsychotics. In neuroleptic malignant syndrome, one thing the Parkinsonism develop, another thing like resting tremors, okay, another thing hyperthermia. So how you can reverse this neuroleptic syndrome? For neuroleptic syndrome, for hyperthermia, you used to like benzotropine there, yeah, benzotropine. So benzotropine is a drug of choice for neuroleptic malignant syndrome. Okay, benzotropine. If hyperthermia there, then dantrolene you can add. Okay, hyperthermia also and muscle spasm there. Jerky movement, hyperthermia, muscle spasm. So serotonin syndrome similar to neuroleptic malignant syndrome, also hyperthermia, also muscle spasm. Okay, very similar. But this serotonin syndrome not give response to benzotropine, not give response. Okay, so it's not be reversed. It's similar to if the patient, listen here, if the patient having schizoaffective or schizodepressive disorder, chronic psychosis lead to depression, then patient using SSRI. So if chronic psychosis or depression is similar to depression, is similar to depression. If the patient developing like taking medication and develop neuroleptic malignant syndrome or serotonin syndrome, how you differentiate? So the serotonin syndrome is due to increased serotonin. Neuroleptic malignant syndrome due to increased depression of dopamine. Okay, decrease dopamine. Understand? To reverse the neuroleptic malignant syndrome, the muscle spasm and hyperthermia, muscle spasm, hyperthermia, bromocriptine there, benzotropine there. So the neuroleptic malignant syndrome you can treat by using bromocriptine, benzotropine. Okay, but serotonin syndrome the patient not give response. Patient not give response to bromocriptine and benzotropine. Okay, the serotonin syndrome they're just due to excessive serotonin because these are serotonin reuptake inhibitor. So they increase serotonin level. They increase serotonin level. Clear? They increase serotonin level. The side effect done. Side effect, most common side effect of SSRI, decreased libido. Okay, must keep in mind. Another side effect, very high level of ADH release. Okay, so this high level of ADH causing what? Water absorption. Water more there. If water more there, automatically sodium down. Water dilution, yeah. So it lead to hyponatremia. Okay, because more ADH. So this more ADH it lead to hyponatremia. And the side effect, serotonin syndrome, wet pillow, GAT upset. GAT upset, for example. Listen, in enteric system, we're using many neurotransmitter. Most commonly, we use acetylcholine. We're also having serotonin there. We're also having dopamine there. We're also having norepinephrine there. A lot of neurotransmitter used in the GIT. So serotonin very high, GIT distress, sometimes constipation or diarrhea, GIT upset, GIT disturb. Okay. The important thing you must keep in mind these three side effects. Not forget these three side effects. Okay. Serotonin syndrome, SIADH, and decrease libido. Have any concern with blood pressure? Because no. Why? Because we're just talking about serotonin. Okay. We not talk about norepinephrine. Yeah. Okay. Now next group, second group, SNRI. SNRI. In SNRI, so these drugs they acting on both neurons, serotonin neuron, 5-HT neuron, and norepinephrine neuron also. Okay, so these drugs are serotonin, norepinephrine reuptake inhibitor. So they are also working on serotonin neuron, also working on norepinephrine neuron. So they block the reuptake of serotonin also. They block reuptake of norepinephrine also. So they're increasing norepinephrine. They also increasing 5-HT. Clear? So they're increasing 5-HT and norepinephrine together. Done? So what is the name of SNRI? In SNRI we're having duloxetine. Duloxetine, not mixed with proxy. Before in previous book, this duloxetine was also belongs to SSRI, but nowadays, now in the recent book is duloxetine, they changed the name to SNRI. Duloxetine also having action on norepinephrine. Duloxetine, another venlafaxine, 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 duloxetine, another desvenlafaxine, desvenlafaxine. Just keep in mind these two and venlafaxine, duloxetine, venlafaxine and duloxetine. So these are FNRI. So they interfere with norepinephrine and they increase inside the brain stem. We have the problem. 5-HT also increases and norepinephrine also increases. Okay, both neurotransmitter increase. Understand? Both neurotransmitter increase. So, so what are the uses of these drugs? These drugs we use for. Here I want to listen about your concept about analgesic system. If you keep in mind analgesic system, these drugs also used for pain. We're discussing here antidepressant and use for pain. How is it possible? If you remember analgesic system, in analgesic system we use serotonin. So these drugs they increase serotonin. So of course they can suppress pain. So these drugs used for neuropathic pain. Okay, for neuropathic pain. The first use of course depression. Another use obsessive compulsive disorder. Same uses. Okay. Another use generalized anxiety disorder. Done. Another use. These three uses common. Same thing. Okay. If any person having like panic disorder, phobia, panic disorder, panic disorder, having stress phobia, height phobia, overcrowding phobia, phobic, phobic disorder, phobia, phobic disorder. Okay, so these are common things: depression, OCD, and generalized anxiety disorder. And another extra use we use for neuropathic pain. Neuropathic pain. So neuropathy. If that there's a neuronal injury, the patient, diabetic patient, they're having neuropathy. Okay, so they're feeling pain, neuropathic pain. For neuropathic pain, for example, trigeminal neuralgia is a neuropathic pain. Okay, trigeminal neuralgia is a neuropathic pain. For neuropathic pain, we're using SNRI. So how is possible this drug working for neuropathic pain? If you remember, the periaqueductal gray matter sending neuron downside in enkephalin and dynorphin. Second neuron, serotonin neuron, Raphe Magnus was here in medulla oblongata. Raphe Magnus producing 5-HT. And this Raphe Magnus produce neurotransmitter again going to spinal cord is your analgesic system. So here in analgesic system you're using 5-HT. Understand? So these drug doing what? They increasing they increasing 5-HT, yeah? So the increasing 5-HT, they can help. If you increase 5-HTs mean they're helping analgesic system. Understand? So they also work in analgesic system. That's why I can prefer for neuropathic pain. For neuropathic pain, this is one group. Another group we later will learn in epilepsy disease. Okay. Another group also used for neuropathic pain. Carbamazepine also used for neuropathic pain. The loxetine we use for neuropathic pain. SNRI we can use for neuropathic pain, especially diabetic neuropathy. Diabetic neuropathy, okay? For neuropathic pain, diabetic neuropathy, the patient have tingling sensation, having burning sensation on feet, okay? So this is a neuropathy. This is just because of neuropathy. For neuropathic pain, we can use SNRI, Deloxetine, okay? For neuropathic pain, Deloxetine. Understand? SNRI. So these drugs, what about the side effect? The side effect, these drugs increase blood pressure. Okay, these drugs increase blood pressure. They stimulate the brain. They stimulate the CNS. Why they stimulate the CNS? They stimulate CNS. So if they stimulate CNS, mean why? Because they increase norepinephrine. Okay, so they increase norepinephrine. They stimulate the CNS. Stimulate effect. Done. So increase BP. Sometimes nausea, vomiting, rare side effects. The important thing here, they have concern with CVS system. They increase blood pressure. Okay. So their side effect less as compared to SSRI. SSRI they causing serotonin syndrome. All antidepressant can cause serotonin syndrome. Okay, because these drugs also you can see they increase serotonin level. Yeah. SSRI selectively they causing serotonin syndrome. If you choose the option like which of following drug causing serotonin syndrome? Number one, venlafaxine, duloxetine, desvenlafaxine, paroxetine. Which option you will choose? Serotonin syndrome caused by following drug. Number one, venlafaxine.